Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and we will continue interview series of one by gastric bypass. Today, with us, this is not only bariatric surgeon. He is a researcher. He's a big name of bariatric surgery and a great contribution in research. So, are you know who is this Professor Kermansaravi? Really, it is great honor for myself to interview such a personality. Just now we were talking about research work, really appreciable, and you all know his research work and his contribution, especially in research work for bariatric surgery. Sir, so much thanks for acceptance our invitation in short period. Just yesterday I asked him and he accept. Really appreciable, sir. Over to you, sir.
Thank you, dear Dr. Imran, for invitation. It's my honor to participate in your program, and greeting from Tehran.
Sir, so much thanks. As you know, so we have started this series. We started with MGB OAGB, that was for 6 months, and we had a sum-up session in June 2021. Then we continue with the series of safe sleeve gastrectomy that also end in December 2021, and also we had a sum-up session in Jan. And then we started this Roux-en-Y gastric bypass with the Professor Hinpan. And during this session, every week, Tuesday evening, this 10 p.m. Dubai time, we had such a session. And today, really, it is great honor. And next month, we will have a sum-up session. Sir, as you know, we have some repeated question. So first of all, personally, I know, but so we are also interested about, so your brief introduction, your journey of bariatric surgery, and especially journey of Roux-en-Y gastric bypass.
I was born in 1977 in Sarin, northern of Iran. And in 2012, I finished my general surgery residency. And in 2016, I finished my 18 months fellowship in MIS and bariatric surgery in Iran University of Medical Sciences, and began my career as assistant professor of surgery in 2017 in Iran University of Medical Science. From 2016, I began bariatric surgery myself, and as the Roux-en-Y gastric bypass has been my favorite procedure, I started in 2016, and I have done more than 1,000 Roux-en-Y gastric bypass till now.
Sir, excellent. Really, now your number of only Roux-en-Y is in tetrafigure. That is amazing. And definitely today, it will be one of the best session. Definitely, we are talking with someone who has personally experienced of Roux-en-Y gastric bypass, more than 1,000 cases. Sir, we have divided this question in 3 sessions. First, we will talk about patient selection and pre-op. Then we will highlight some technical points, and then we will talk about post-op. So according to, yes, I know some data, and also you are a researcher, you know much better than me, guidelines and everything. But what I want to know, because always we talk about different ethnicities, different dietary habits. So now your main practice is in Tehran, and you deal more Iranian people, and they have a special diet protocol. According to your experience, what is main? So this in patient selection, when you select the patient, relative and absolute contraindication of Roux-en-Y gastric bypass.
I think the contraindications, absolute contraindications, is the contraindications for any elective surgical procedures. I think we don't have any absolute contraindications for Roux-en-Y gastric bypass. But We have some relative contraindications, such as a small bowel disease, especially Crohn disease, or in some patients who they are substance drug abuser, especially current drug abuser or who used in past 1 year. I think it's a relative contraindications, or the patient with low mental capacity, or the patient with that are immobilized. I think these are the main relative contraindications for any gastric bypass surgery, such as Roux-en-Y gastric bypass.
Sir, so much thanks. Sir, what about, what is your opinion about a patient who is suffering with the cirrhosis, child C, and also morbid obese? Is it also a relative contraindication?
Uh, do for super obese patients. I mean, BMI over than 50. Uh, I perform for the patients with super obesity, generally one anastomosis gastric bypass. I think Roux-en-Y gastric bypass uh, has less efficiency in these patients. For child C, I think we can do Roux-en-Y gastric bypass. However, a sleeve gastrectomy may be a better option in this patient, but I think Roux-en-Y gastric bypass has no contraindication in cirrhotic patients.
Have you any experience?
Yes, I did some Roux-en-Y gastric bypass in cirrhotic patients in our center, me and the Professor Pazuki.
And there was no issue. Sir, regarding this smokers, you also highlighted. So, because one of the main issue after one by gastric bypass is marginal ulcer, and in detail we will discuss in the next session. So this is always a concern after one by gastric bypass, and one of the main reason and the cause is smoking. So how you deal with smokers? Someone is a heavy smoker, and also there is no other issue, and you are going to do one by gastric bypass. How you deal with someone?
The patients, the smoker patients, should be stop smoking at least 6 weeks prior to surgery. It's not differ between Roux-en-Y gastric bypass, OAGB, or a sleeve gastrectomy. They should stop the smoking before the surgery. And I don't allow them to use cigarette smoking after surgery. I think smoking can increase the incidence of marginal ulceration, both in OAGB or Roux-en-Y gastric bypass. I don't think it's differ between these procedures to use cigarette after surgery.
Sir, excellent. One of the issues, so after Rowan by gastric bypass or any type of hypoabsorptive bariatric surgery, so definitely that is micronutrient deficiency. There is no doubt. So we face, if a patient after menopause, that is symptomatic osteoporosis, symptomatic. And also when, how you deal, first of all, is it necessary to go for osteodensitometry or some other paraclinics or to rule out these patient is symptomatic osteoporosis?
It's better the patient do lab test every 1 year after the surgery, after the first year after surgery, should do the lab test such as calcium, PTH, vitamin D, and they should receive vitamin D as supplement and calcium also, other multivitamin minerals, I think, for the lifeline. But bone densitometry is not routine in Iran. I think most of bariatric surgeons uh, don't recommend a patient for routine bone densitometry. But in presence of any symptoms of bone pain, I think we should consider to recommend the patient to do bone densitometry.
Yeah. And if there is a confirmed osteoporosis, so or you will go this medical treatment before surgery, and when there is medical treatment is sufficient, then we can go for Roux-en-Y, or no, you will prefer sleeve gastrectomy in such a case, or SAJ or SASI, because in SASI or in some cases, yes, definitely we about 40% of food will pass from duodenum, and maybe that a patient will face less issues for micronutrient deficiency. What is your opinion, sir?
Um, Bone osteoporosis may occur after any type of bariatric surgery. I think, as it has shown in previous studies, it has a chance of uh, osteoporotic changes after any type of bariatric surgery. It may be increased after malabsorptive procedure, but it's as the same as in sleeve gastrectomy and Roux-en-Y gastric bypass. I mean Roux-en-Y gastric bypass with short biliopancreatic limb. Mainly, it's a restrictive procedure uh, more than its hypoabsorptive mechanism. Um, also, also I use a long biliopancreatic limb in my patient.
Excellent. We will also talk about billiard in a technical session. Sir, about pre-op endoscopy or H. pylori eradication. So is it routine in your practice?
It's of our center's policy. All patients before any bariatric surgery should do upper GI endoscopy with random biopsies to rule out H. pylori and other pathologies such as intestinal metaplasia that may change the option of surgery. And all H. pylori positive patients should undergo H. pylori eradication between the surgery. And the H. pylori eradication should be confirmed before the surgery. It's our center's policy.
Sir, my question regarding this, because I know your center is one of the busiest center in Middle East. There is no doubt. Till I can ask. So at the Globe, so like Mohit Bhandari, his center is really busiest, and I also know about your center. That is one of the busiest center for bariatric and also academic activities and educational center. So what is my question regarding pre-op endoscopy? And also, I know you follow your data. Which percentage of your patient you have changed your decision after upper endoscopy? Or you think about Roux-en-Y gastric bypass, just when you did this, oh, there is a polyp in duodenum, there is a polyp in antrum, and patient need to follow up. This patient is not good candidate for Roux-en-Y. We must go for sleeve or vice versa. So which percentage you have changed? About 5%, 1%, 2%? No, because your figure is in tetra, thousands.
I can't say the exact percent, but I can estimate at least 5 to 10% of patients may have some pathologic findings that may change the procedure.
Sir, it is great message for my youngsters, because why I ask this question? Someone think though upper endoscopy is not important, so this is important. When you change your decision, just imagine whose figure is in tetra in thousands of cases and change decision 5 to 10%, that will be in hundreds. So definitely it's more important. Sir, regarding age limitation, for Roux-en-Y gastric bypass, what is your protocol in adolescents or older age? Have you any age limitation?
I have no age limitation for Roux-en-Y gastric bypass. Generally, we do a sleeve gastrectomy in children with severe obesity associated medical problems such as severe sleep apnea. We may do bariatric surgery in children for these reasons. And the first choice is sleeve gastrectomy, but we have no limitation of age for Roux-en-Y gastric bypass. According to the endoscopy and other symptoms such as severe GERD, we may select the Roux-en-Y gastric bypass in even children or adolescents, and we have no upper limit for elderly patient. It's a very good option even for elderly because the nutritional deficiencies is very low after Roux-en-Y gastric bypass. I think nutritional deficiency is very rare after Roux-en-Y gastric bypass, and it can be a good option in all ages.
Thank you, sir. Thank you so much. And now, because we will talk about some technical questions and this session. So, if you have any video, any presentation, we are interested to watch. So, your short video, and then we will explore different. We will talk about different questions for your technique.
Okay, let me show the video.
Yeah, yeah.
Uh,
Yes, you can click that. Yes.
you see?
Yeah, yeah. I can.
We routinely start from his angle to reach the his angle and uh, finding any hiatal hernia, and I usually divide the omentum to decrease the tension of and I usually create a semi-long pouch uh, between 8 to 10 centimeter is my pouch, and I created over a 36 French bougie. I create the pouch usually with three or sometimes such as this patient 3.5 staplers. Gastrojejunostomy is always anticolic and retrogastric. I usually select 125 centimeter of biliopancreatic limb. I mean line biliopancreatic limb is my technique. Can PDS 20 to close the defects. I mean gastrojejunostomy. They create the jejunostomy 75 centimeter to prevent the reflux. I mean alimentary limb 75 centimeter. And jejunostomy about 4 centimeter. Then I close both defects, both jejunal and Peterson defects. It's Peterson defect with non-absorbable suture. And finally, I perform Ehrlich test.
Sir, excellent demonstration, really. And with this a short video, we receive all the message. So regarding this BP limb, so have you any criteria like age, BMI, or comorbidity? Just imagine patient 60 years old with BMI 55 and diabetic patient, a patient 40 years old with BMI 40 without any comorbidity. So this BP limb will be changed with the age, with the BMI and comorbidities, or no? You have a standard BMI. Just BP
It's
limb.
not related to comorbidity. I use a constant 125 centimeter biliopancreatic limb in iron patients below 50 BMI and below 65-year-olds. In elderly patients over 65 years old, I create a 1 meter biliopancreatic limb, not smaller than 1 meter. And the alimentary limb is constant in all my patients and is 75 centimeter to prevent the reflux after the surgery.
Sir, excellent. Sir, regarding this, because every person said this is an evolution of technique. Definite when you started Rowan by gastric bypass. So personally, you see, yes, if I do like this, pouch size will be this. So anastomosis, this gastrojejunostomy, like this will be better and better. Can you highlight those points that you have changed during this journey of Rowan by gastric bypass?
No significant change, only I increase the size of gastrojejunectomy from 3 centimeter to 4, some stenosis, and then I change the gastrojejunectomy from 3 centimeter to 4 centimeter, and also I change the jejunal anastomosis from 6 centimeter to 4 centimeter to prevent intussusception after the surgery.
Have you faced any interception when you were doing 6 centimeter, that JJ anastomosis? Have you faced any interception?
I have no clear intussusception, but when I study in literature, I found that it's better to be about 4 centimeter to prevent intussusception. No, I have not any intussusception in jejunal anastomosis till now.
Sir, another thing that you have highlighted regarding your length of pouch, that is little longer than a standard Rowan by gastric bypass. And definitely you are below second vein. So someone they prefer, so between first and second, and someone below second, and definitely when your pouch is 6 to 7 centimeter, you're below this, and then the size of your pouch is little bigger, then there will be more acid production and more chance of marginal ulcer. So, what is your percentage? So, about marginal ulcer.
In my patient, I have seen less than 1% for marginal ulceration. Uh, it's a theory that more acid are more ulcer. But in literature, when we search, we can find that uh, marginal ulcer risk in extra large pouch. I mean a 10 centimeter pouch and a 5 centimeter pouch, a short pouch, have the same marginal ulcer incidence. It's in RCT published by Bourbon in 2020, published by Obesity Surgery or SORT. Uh, it shows that the size of the pouch can't have significant effect on marginal ulceration. There are some studies or another study in 2022 shows that pouch size, a very line pouch size, may can affect of a marginal ulcer formation. But it's an issue. It's an issue. Not any consensus about the size of the pouch. In our center, we usually create the pouch below the second vein of anterior part of stomach uh, and a lung biliopancreatic limb. I mean a lung pouch with a lung biliopancreatic limb, and we have acceptable result. I want to show my patient. I don't know. Can show. Um, can you see?
Yeah, yeah, I can see. Please, if you want to share any presentation, sir, we can see.
It's the excess weight loss percent of my patient, only my patient,
So still,
about
I cannot see your presentation,
1,000.
sir. Ah, yes, yes, please.
Uh, it's the excess weight loss chart of my patients with a 5-year follow-ups, about 1,200 patients that I have performed Roux-en-Y gastric bypass with lung pouch and the lung biliopancreatic limb. As you can see, it's an acceptable excess weight loss in 4 years. And in 5 years, because very few patients reach the 5-year follow-up, it's high. But the most reliable excess weight loss in 4-year follow-up, which the patients is more, and it's acceptable weight loss during a midterm period. Uh, I have no hypoalbuminemia in these patients, any hypoalbuminemia, and with good excess weight loss. So I don't change my strategy and our center policy. It's, I think, a successful policy with a lung pouch and lung biliopancreatic limb.
Sir, excellent. Definitely, you are working in a center that is a academic center and follow all guidelines. And personally, I know that center till I learn in that center, and it's great honor for myself. I am trainee of that center, and I know personally how they follow up, pre-op, post-op, and everything. Sir, regarding this hiatal hernia, how you deal a patient with large size hiatal hernia. So if you are going to do Roux-en-Y gastric bypass, and as you have mentioned earlier, there is no absolute contraindication, and just now you decided to do, are you repair that hiatus in the case of 5 centimeter, 4 centimeter? Have you any criteria to repair hiatus?
Also, sages recommend to repair all hiatal hernia during all bariatric surgical procedure. But I think there is not any high-grade evidence to support the sage's recommendation. It's only a recommendation or a suggestion without any high-grade evidence. I think we can don't to try repair uh, a small to moderate size hiatal hernia. I agree that it's better to repair large, and it's mandatory to repair extra large or huge hiatal hernia. But in presence of a small to moderate hiatal hernia, we can leave them alone without repair. Uh, I will publish our paper, uh, our experience about Roux-en-Y gastric bypass, that we didn't repair a small to moderate size hiatal hernia and the patients uh, didn't have any severe GERD after the surgery. I think it's not mandatory to find and repair all hiatal hernia is in any size during Roux-en-Y gastric bypass. Only it can be a recommendation.
Sir, excellent. Sir, regarding this gastrojejunostomy, you have mentioned, so you increase 1 centimeter. Before it was 3, now it is 4 centimeter, about 4 centimeter. One of the, this Roux-en-Y gastric bypass is, the main component is restriction, not hypoabsorption, not malabsorption. So the main object in this procedure is restriction. So how much you face weight regain? Yes, I understand you increased that BP limb. Now your standard BP limb is 1 to 5, not that standard that was the standard Roux-en-Y. So because you increased hypoabsorptive, definite then less restriction but more malabsorption, or that component is a little dominant. So which percentage of your patients are facing weight regain?
According to our database and follow-up, we have less than 1% of weight regain after Roux-en-Y with lung biliopancreatic limb. According to the definition, that the patients that have BMI more than 35, uh, this definition for weight regain, we have less than 1%.
Sir, one question. Just this is the technical question. So, because I know in that center, one of the another most popular procedure is OAGB, one anastomosis gastric bypass. Have you any comparative study between OAGB and Roux-en-Y regarding micronutrient deficiency?
Uh, we are doing a study to compare Roux-en-Y gastric bypass, lung BP, Roux-en-Y
Yeah,
gastric
yeah.
bypass, and OAGB, but it's not finished until now. But as a initial evaluation, nutritional deficiency is more in OAGB, even with OAGB with 1.5 meter. It's higher nutritional deficiency in OAGB.
So when we do OAGB with the 1.5 meter, definitely the BMI is low. We never do 1.5 meter in BMI 50. Then okay, the maybe patient is some this comorbidity, diabetic patient with BMI 35. Okay, we will do 150. So when we will go for BMI 50, definite we will be 200 plus. There is no doubt. So which thing I want to highlight? So if we bypass more, so if I can convey my question, that will be maybe because you are a researcher man, and you will think about this what I am asking. So when we bypass more jejunum, that is the main part for our this absorption of micronutrient, we will face more micronutrient deficiency. Due to this, in OAGB, we will face more. So what is my idea? You can go standard Rowan-Y just with BP limb 50, not 125. Go with BMI, this BP limb 50, but your rule limb is 75. In same session, so you can increase like sugar man. Okay, now what will happen? So now your BP limb is more ileum, not jejunum. Okay, so you increase your, yes, you increase, go for 150, 125. Now, I don't know how much you want to increase your BP limb in same session. Okay, little difficult. Again, you do JJ, again, you will do jejunostomy, maybe 20 minutes more, but you reserve your jejunum pure for absorption. So, is it possible in future? Can you do some cases? And then you compare, yes, now we achieve weight loss sufficient, and but with less micronutrient deficiency. That is really a main challenge, especially in our areas. Their patients has so access to less supplements and follow up and these things.
It seems every procedure is more potent. It may have more nutritional complications. As you said, I agree with you. When we increase the malabsorption part of the procedure, we may prone the patient to more nutritional deficiencies. It's only suggestion that common limb more than 4 meter may decrease the nutritional deficiency after both OAGB or Roux-en-Y gastric bypass. But in Roux-en-Y gastric bypass, common limb plus alimentary limb equal to total alimentary limb lengths. And total alimentary limb lengths of 4 meter or more can decrease the nutritional deficiency, not exactly prevent all nutritional deficiency. No, it can decrease the nutritional deficiency.
Sir, so much thanks. Sir, another issue that is also, in my opinion, is nightmare after Roux-en-Y gastric bypass is internal hernia. Routinely, you close the both defects. Have you faced any internal hernia after also closing your defects?
Okay. I had at least 3 internal hernia, despite I closed both of the defects. Both of the defects, meanwhile, about 1 year after the surgery, 1 year. And closing both defects can't prevent absolutely of internal herniation. It can significantly decrease the incidence of internal herniation after Roux-en-Y.
Sir, yes. So regarding this, because we have one question from Facebook, Dr. Mijda Ismail from Iraq, regarding this BP limb and BMI. Yes, we already talked about this, and professor also this manage his BP limb on the base of BMI of the patient and comorbidities. Sir, regarding this, because we also will talk little about, we are also already talking about post-op. Have you faced any intractable marginal ulcer after Roux-en-Y gastric bypass and there was no response to medical therapy and you go for surgical intervention, and what you did in that case?
I have few cases with retractable marginal ulcer, and I cut the gastrojejunostomy, dismantled the gastrojejunostomy, shortened the gastric pouch, and recreate the gastrojejunostomy.
Revise that gastrojejunostomy. And then there was no issue, patient was happy?
No.
And sir, regarding this post-op endoscopy, have you any protocol for your patients?
No, as you know, if so, only recommend post-op endoscopy in symptomatic patients or in OAGB or sleeve gastrectomy 1 year after surgery and then 1 to 3 years after surgery, because there is a risk of bile reflux in both sleeve gastrectomy and OAGB. But there is no recommendation to routine endoscopic follow-up in Roux-en-Y gastric bypass.
How much your patients they are symptomatic after Roux-en-Y gastric bypass, and there was compulsory to go for upper endoscopy.
Uh, I think less than 1%. As I mentioned before, the risk of marginal ulceration in our patient it may be underestimated, but according to the patient's symptoms, uh, I estimate that we have uh, about 1% of symptomatic patients who needs upper G endoscopy after Roux-en-Y gastric bypass.
And what was the main finding in that 1%?
It's a marginal ulceration.
There was marginal ulceration. And regarding these patients that you follow, especially after Roux-en-Y gastric bypass, and you do this. What is my question regarding H. pylori? Definitely, you check H. pylori in these 1% marginal ulcer. They were all positive for H. pylori or no?
Most of them are H. pylori negative
Excellent.
after the surgery, despite the finding of marginal ulceration. Most of them are H. pylori negative.
Sir,
I
another.
think other factors such as most of them are a smoker
Yeah, this
or
was my
or
next
or
question.
use NSAIDs or aspirin.
Yeah, this was my next question. So definite, there was some initiative. So all of them, they were are smokers or NSAID user. So this is we must be careful if someone is heavy smoker or using chronic this NSAIDs due to any osteoarthritis or something like this. So maybe Roux-en-Y is not better chance. If we will go for sleeve gastrectomy, that may be better option. Sir, regarding these cases, so one question, definitely maybe if you have not till this time, yes, you highlighted these are marginal ulcer, what smoker or NSAID user. So we can compare also these patients before surgery. Yes, now they are H. pylori negative. Have you any data? These patients were also negative before surgery or no? They were positive. You eradicate H. pylori, and now also they are negative. Have you any study, or maybe in future your any fellow can do this?
We are doing a study. We'll publish in next month. God
It's
willing, we have initiated this study with one of my residents, and it's finished now. Uh, Let me don't talk about the result because it will published soon.
why I am asking, sir, because if we highlight these things, why we started this interview, this is the main reason. Because now I am talking with someone who has a lot of experience in Roux-en-Y gastric bypass, who is researcher, who read everything, who know everything. And now when this message will go for the world, for our youngsters. So what the main issue after Roux-en-Y was, two main issue, marginal ulcer and internal hernia. If you can solve these issues, definite, then it's a good surgery. So we can, this Roux-en-Y is excellent surgery, definite. So due to this, I want to highlight these topics and these points. So definite, next month we will see your study, and hopefully this will be definite excellent study and a great message for our youngsters. So regarding weight regain, you highlighted, yes, there are less cases. How you deal your cases if there is weight regain after Roux-en-Y? Only medication, or it was necessary to go for surgical intervention?
Uh, every weight regain, or it's better I say that every revisional surgery, before doing every revisional surgery, we should do radiographic evaluation, imaging, endoscopy, and the patient should be discussed in multidisciplinary team. Nutritionist and gastroenterologists, maybe endocrinologists, and the surgeon and the bariatrician should have a discussion about the patient, that if the patient have the second or the third surgery, uh, can have benefit from the surgery, and the patient should be educated. If the patient are not fit for the surgery for weight regain after Roux-en-Y gastric bypass, I usually do distal gastric bypass. I mean, I elongate the biliopancreatic limb. Uh, it's not related to total ball length. I will measure the total ball length, and uh, I save 4 meter of total alimentary limb length. As I mentioned before, the common limb plus alimentary limb should be 4 meter. I mean, I elongate the biliopancreatic limb in these patients to have a total alimentary limb length 4 meter, at least 4 meter, and I trim the pouch if the pouch has enlargement, and I cut any remain candy cane. As we know, candy cane is a risk factor for weight regain. Generally, as I said, I use the uh, distalization, distalization Roux-en-Y in weight regain after Roux-en-Y gastric bypass.
It's good. It's good. So yes, you prefer this, and also, if any, so you prefer to save elementary limb, common channel with the rule limb, plus that total elementary limb must be 4 meters. Sir, regarding this phobia ring or any that band of this gastric pouch, what is your opinion?
I think it's an effective method, but I have no experience about using phobia band or other bands to increase the restriction. I have no experience.
And what about this endoscopic intervention like resizing the pouch, resizing this gastro, jejunostomy? So definite when we will increase
Endoscopic,
this. Yeah.
uh, I know that we published a systematic review meta-analysis in 2021 about revision procedures after Roux-en-Y gastric bypass for weight regain. We published it before, and we evaluate all revisional surgery after Roux-en-Y gastric bypass for weight regain. We reported then endoscopic procedures are the most safe procedures, but they have at the least efficacy, and efficacy is more in distalization and in conversion of Roux-en-Y gastric bypass to uh, biliopancreatic diversion. But I have no experience to convert Roux-en-Y gastric bypass to biliopancreatic diversion. As I mentioned before, I use only, or mainly, it's better, I said it's mainly, I mainly choose distalization.
So distalization is your preference in case of, sir, sometime we follow all the standard, we do exactly the surgery that you do, but at the stage patient stuck to lose weight. Yes, lose weight like 40%, 50% excess body weight. So in such a situation, have you experienced to use medication like GLP-1, this so such a derivatives so available in market?
Okay. So, often we should help with medication to patient, but the result is not is not very good or as the same as the surgery. Uh, we should uh, we should say the patient before any revisional surgery that your body response is lower and uh, delay with delay uh, compared to the first surgery because your bodies have adaptation to the first surgery and the results is not as good as the first surgery. The patients should educate it before the surgery.
Yeah, definitely. No, because my asking, so when sometime we do surgery, initial surgery, and sometimes so weight loss stuck. So patient yes lose weight, then stuck, and oh, then there are some complaints from the patient. So I am not losing weight. No, 1 month, 2 month, 3 month, and that stuck. Sometimes we use Saxenda, Victoza, Trulicity, different names now in the market like Ozempic, and now more and more. So these are GLP-1 derivatives, and maybe when we do some injections for the patient, it start again to lose weight. My question was about this. Have you any experience to use these derivatives in initial surgery?
In initial surgery, our colleagues in nutritionist colleagues or endocrinologists sometimes prescribe Victoza, for example, but its effect is not significant.
That's
As you know, they have transient effect, not persistent effect.
Sir, regarding this, because now I remember when bariatric surgery started, so that was gastric bending, and after that time, so sleeve gastrectomy, Rowan Y, and many different types, and also before that, that was the BPD, and that was duodenal switch, and many, many. So how you see the future of Rowan Y gastric bypass?
I think lumbar gastric bypass is a good procedure, but be, despite my uh, despite that lumbar gastric bypass is my favorite surgery, but I think we have not any gold standard surgery. Any every surgery has the advantages and its defects and disadvantages. Uh, I think we should select the type of surgery according to the body habitus, BMI, nutritional habitus, endoscopic findings, family history of uh, some hereditary disease, cancers, and comorbidities. So I think maybe OAGB will increase in next years because it has more efficacy compared to other procedures. Uh, I think the future will a competition between Roux-en-Y gastric bypass and OAGB, and I think a sleeve gastrectomy may decrease, uh, such as gastric band, because it's less efficacy, and as you know, because of de novo GERD and sometimes Barrett esophagus in midterm or long term after sleeve gastrectomy. Another advantage of OAGB and Roux-en-Y gastric bypass that these procedures are completely reversible. So uh, against the sleeve gastrectomy that it's a irreversible procedure, I think, as I said before, future is belong to Roux-en-Y gastric bypass and one anastomosis gastric bypass.
Which percentage of your bariatric surgery cases belongs to Roux Y gastric bypass now in 2022?
How much?
Yeah, yeah. Which percentage? So now Roux Y gastric bypass, because you are doing, as I know, you are doing also OAGB. You are doing all types of surgery. Which percentage of total your bariatric surgeries belongs to Roux Y gastric bypass now in just now your recent practice?
About 50%.
50 is exact.
Half of my surgery is run by gastric bypass, 50%.
Excellent, excellent. Sir, according to your opinion, so what is your main concern after Roux-en-Y gastric bypass? So because now you are following your patients, your number of cases is in tetra, and also you are dealing with the patients. Also, you are facing your patient after OAGB, after sleeve, after Roux-en-Y. But after Roux-en-Y, what is your main concern? So this is a marginal ulcer, that is the less weight loss, that is the internal hernia, chronic pain. So what is your main concern?
I think the internal herniation is the Achille, is the Achille of Roux-en-Y gastric bypass, and another issue, it's um, endoscopy follow-up for all gastric parts. As you know, Iran or um, other countries near Iran are at increased risk of gastric cancer.
Yes. And this is the
We
main.
are not available to evaluate all parts of stomach after Roux-en-Y gastric bypass. It's the most concern after gastric bypass. Um, even not differ between Roux-en-Y or OAGB.
Have you faced any gastric cancer in remnant in both cases?
We have one case. We have one case that have gastric cancer in antrum after the surgery. Uh, I think 2 or 3 years after the surgery. Despite we have done endoscopy and biopsy before the surgery, but the patients got gastric cancer after the surgery.
And patient has any family history positive for gastric
No,
carcinoma?
no.
And in case of family history, and I know the some region of, I think north of Iran, Gurgan or these areas, there is the more chance of esophageal carcinoma or gastric carcinoma in a patient in those from those regions. And if they have any family history positive for gastric carcinoma, then definitely you will go for a sleeve gastrectomy if there is no restriction for a sleeve.
I choose in these patients a sleeve gastrectomy or a sleeve plus procedures, such as SASI procedure or SAS procedure is it's best option for these patients.
Excellent, excellent, sir. Sir, really so much thanks. And yes, the Professor Juan Carlos also appreciate you on Facebook, and he's watching your interview. Thanks, Juan. Sir, regarding really so much thanks and for your time. This was no doubt one of the best session. So, your message for our youngsters who are just now going to start bariatric surgery.
I think that a perfect bariatric surgeon uh, uh, should should know at least 2 or 3 bariatric procedure and do not insist on one bariatric procedure. We should select the best procedure for each patient individually. Uh, as I mentioned before, we have not any gold standard procedure. The best procedure for each patient may be differ according to the patient's demographic or endoscopic or other criteria.
Sir, so much thanks, really, and a great appreciation for your contribution, especially at international level, especially for your research work. That is great honor for us. And really proud of you. So much thanks, my viewers. These sessions are due to your interest. If you have any question from Professor or from myself, you can ask in comment and you can contact personally. We will continue this series of Roux-en-Y gastric bypass, and next week, Tuesday, 10 p.m. we will be with another legendary bariatric surgeon. And we will continue this. And next month, just in June, we will have some obsession. And from July 2022, we will go ahead with metabolic surgeries in low BMI. And 2023, we will talk about redo. Sir, so much thanks. And we need your support and also guidance, especially when we will go ahead in another interview series that will be a metabolic surgery in low BMI. Again, so much thanks for your support and guidance.
Thank you. Goodbye.
So much thanks. So much thanks. Good night, sir. Have a nice time, sir.
Good night.